Bon matin tout le monde et bienvenue à cette mise à jour sur le COVID-19 au Nouveau-Brunswick. Speaking on behalf of the province today are Dr. Jennifer Russell, the province's Chief Medical Officer of Health, the Honorable Dorothy Shephard, Minister of Health, and joining us today is Dr. Gordon Dow, Infectious Disease Specialist with the Horizon Health Network. Les porte-paroles aujourd'hui sont la médecin hygiéniste en chef, la Dr. Jennifer Russell, le Dr. Gordon Dow, spécialiste des maladies infectieuses au réseau de santé Horizon, et l'Honorable Dorothy Shephard, ministre de la Santé. Dr. Russell.
Thank you, Bruce. Merci, Bruce. Bonjour à toutes et à tous. Good morning, everyone. Depuis notre dernière conférence de presse lundi, 2 autres personnes sont décédées des suites de la COVID-19. Ces 2 personnes étaient âgées de 80 à 89 ans. L'une résidait au manoir Bellevue, un établissement résidentiel pour adultes à Edmundston, alors que l'autre, décédée plus tôt aujourd'hui, résidait à la Villa Desjardins, un établissement résidentiel pour adultes à Edmundston. J'offre mes plus sincères condoléances à la famille et aux amis de ces 2 personnes, ainsi qu'à toutes les autres personnes qui ont perdu un être cher en raison de ce virus. Since our last news conference on Monday, 2 people have lost their lives as a result of COVID-19. Both individuals were 80 to 89. One was a resident of Manoir Bellevue, an adult residential facility in Edmundston, and the other, who passed away earlier today, was a resident of Villa Desjardins, an adult residential facility in Edmundston. I am sending my heartfelt condolences to families and friends of these individuals and to everyone who has lost a loved one to this virus. Today, there are 2 new confirmed cases of COVID-19 in New Brunswick. In Zone 1, which is Moncton and southeastern New Brunswick, there is 1 new case. The other case is in Zone 4, which is the Edmundston, Grand Falls, Saint-Quentin region. We now have 161 active cases of COVID-19 in New Brunswick. There are 6 individuals now in hospital, 2 of whom require intensive care. I ask that you keep these fellow New Brunswickers in your thoughts and prayers. We will be updating these figures on our dashboard later this morning. Aujourd'hui, j'annonce qu'il y a 2 nouveaux cas confirmés de COVID-19 au Nouveau-Brunswick. Il y a un nouveau cas dans la zone 1, soit la région de Moncton et du sud-est du Nouveau-Brunswick. L'autre nouveau cas est dans la zone 4, soit la région d'Edmundston, de Grand-Sault et de Saint-Quentin. Il y a maintenant 161 cas actifs de COVID-19 dans la province. De ce nombre, 6 personnes sont hospitalisées après avoir contracté le virus, dont 2 aux soins intensifs. Nous mettrons à jour les données de notre tableau de bord plus tard ce matin. Last week, the first cases of the UK variant of COVID-19 were confirmed in our province. And since then, we have received many questions from New Brunswickers. We have all heard that these variants are more easily transmissible and can spread more quickly. But I know that many people are still unsure about what that means for New Brunswick as we continue to move through this pandemic. Aujourd'hui, je suis heureuse que le Dr. Gordon Dow puisse se joindre à nous pour faire une présentation spéciale sur les variants de COVID-19. Le Dr. Dow est un spécialiste des maladies infectieuses au réseau de la santé Horizon. Il est également membre du groupe de travail sur la pandémie du Nouveau-Brunswick. Après sa présentation, le Dr. Dow répondra aux questions des médias et répondra également à certaines questions que nous avons reçues des citoyens par l'intermédiaire des médias sociaux au sujet des variants de la COVID-19. Today, I'm pleased that Dr. Gordon Dow is joining us to deliver a special presentation about COVID-19 variants. Dr. Dow is an infectious disease specialist with Horizon Health Network, and he is also a member of New Brunswick's Pandemic Task Force. And we were talking just before the press conference about the fact that it was April 6th of last year that he joined the Pandemic Task Force, and he drove to Fredericton to be here in person. And at that point, we had been in lockdown for about 3 weeks. And the only people that I had seen, the only human beings I had seen were the people that worked at the Department of Health. And so when he walked through the door, the first thing I did instinctively was stick my hand out to shake his. And he just sort of stood back and went, oh. So it's incredible how our behaviors have changed as a result of COVID since then. But anyway, it's nice for him to be here in person today. So following his presentation, Dr. Dow will respond to questions from the media, and he will also address some inquiries we've received from the public through social media about COVID-19 variants. And Dr. Dow brings a great deal of experience and expertise to this subject, and I know he will be able to provide you with some very important and helpful information about the variants. I would like to invite him to the podium now to begin his presentation. Thank you very much. Dr. Dow.
Merci beaucoup, Dr. Russell. Bonjour à tous. C'est mon plaisir de vous présenter ce matin. Good morning, everyone. I've been asked to give just a brief update on the basics of science behind new variants, and thank you very much, Dr. Russell and Minister Shephard, for the opportunity to take a few minutes to do this. So the best way to describe the virus that causes COVID-19 is it is a thief. It's a thief that tries to break into your house and steal all the furniture. You should think of the cell as the house and the machinery in it as the furniture, and the virus is the thief. So how does the virus get into the house? Well, it needs a key. And if you look on this first slide, you'll see those yellow spikes on the outer surface of the virus. That's the key that lets the thief into the house so it can steal the furniture. So, le spike protein est représenté par les boutons jaunes entourant le virus. Le spike protein est la clé que le virus utilise pour ouvrir la porte et entrer dans nos cellules. Les mutations de la spike protein rendant les nouvelles variantes 50% plus contagieuses. Next slide, please. I just want to show a cartoon on what 50% more contagious looks like. Now, it's 30 to 80% more contagious, depending on which study you look at. Let's say it's 50% more contagious for this example. We measure the contagiousness of the virus by a thing called the reproduction number, which is R. So if the reproduction number is 1, you have the same number of cases every day, which is what we were seeing in New Brunswick a couple of weeks ago when we had, 20 cases every day, 20, 24 cases. Our reproduction number was 1. That means everybody with COVID was infecting one other person every 4 days. Now, if your reproduction number is above 1, that leads to exponential spread of the virus, which means instead of just infecting one more person every few days, you're actually infecting 2 or more. And that's what leads to exponential spread. So back about 3-4 weeks ago, the reproduction number in some parts of the province was about 1.5. Some places it was more, some places it was less. If you follow 1 month of transmission cycles, that would have led to 675 infections and 5 deaths in New Brunswick. Interestingly, if you look at what happened to us in January, that's just about what we saw. Now, let's make it 50% more infectious. So now the reproduction number, instead of being 1.5, is 2.25. Well, over 1 month, instead of 675 infections, we would have seen over 2,000 infections and 18 deaths. So what do we know about COVID-19 variants? Well, they rapidly replace older strains. They are more fit. So they will replace the older strains that are in Canada right now, usually in about a 3-month period. They can infect people who have recovered from the older strain of COVID-19. Some vaccines are less effective against these variants, or at least some of these variants. Younger people, which were relatively spared from the older variant, are vulnerable to the new one. And the final thing, the piece of good news here, is that public health measures work. If you look at countries where there are variants circulating right now, like South Africa, Ireland, and the UK, they are actually bringing their numbers down through a combination of public health measures and vaccination. So we're going to go to the next slide, which is slide number 4, which is the the cartoon which shows what happens when you bring in vaccination and public health measures, and you bring the reproduction number to less than 1. So if we bring the reproduction number less than 1, which is where it is in New Brunswick right now, and apply that to what happened a month ago, we could have had as few as 146 infections or less and only 1 death. La bonne nouvelle, les mesures de santé publique sont efficaces contre les nouvelles variantes. Si nous suivons ces mesures, le nombre de reproductions peut être réduit à moins d'1. Cela entraînerait une réduction significative des infections et des décès. So the last slide. How do we prepare? Well, the way we prepare is we continue to follow our public health guidance. We limit our social networks to what we're supposed to do in the orange phase. We don't go to work or school if we're sick. We get tested if we have symptoms. We wear a mask, we wash our hands, we don't touch our face, we cough into a tissue or a sleeve when we do cough, and we clean and disinfect household surfaces frequently. So what does all this mean? Well, this virus is a thief, and it doesn't just infect our cells, it actually steals a lot more than machinery in our cells. It steals our freedom, it steals the education of our kids, it steals jobs, and we need to apply these public health measures to stop this from happening. So when you're at the border and things are difficult to get through the border, remember, those measures are designed to keep the thief from coming into New Brunswick. When you're in an orange zone and you're complying with those restrictions, like having your straight 10, remember, you're doing that to keep the thief out of your zone and out of your town. And when you wash your hands and wear a mask, you're keeping the thief out of your house. And finally, when you get a vaccine, you're keeping the thief from getting a key to cause infection. Thank you very much.
Good morning, bonjour. I would like to take a moment to express my sincere condolences on behalf of all New Brunswickers to the loved ones of the person who passed away earlier this week, and to the loved ones of the person who passed away today as a result of COVID-19. Our thoughts and prayers are with the family and friends of both of these individuals at this difficult time. I want to thank Dr. Dow this morning for his informative presentation and for being here today to respond to questions from the media and the public. Now that we have confirmed cases of the UK variant of COVID-19 in New Brunswick, I know that we all have questions. I hope today's presentation provided clarity and addressed at least some of these concerns. The situation is constantly evolving during this pandemic, and I believe it's crucial that we all do our best to stay well informed. Accurate and up-to-date information is the best tool we have when it comes to making the right decisions to protect ourselves and our loved ones. Aside from the variant, I know many people have questions about when we will consider moving zones back to the yellow alert level. We want to get all of the areas of our province back to the yellow level as soon as possible, and we also want to bring the Atlantic bubble back. But we must go about it the right way. Health zones will need to remain in the orange level for at least 2 or 3 weeks, giving the province time to stabilize the number of COVID-19 cases before we can consider the possibility of moving to yellow. The situation is still precarious, and one wrong move could lead to an increase in cases. We are constantly analyzing the situation, and we are working closely with public health. Right now, public health is also looking closely at the guidelines under the yellow level to determine whether any changes should be made to best ensure the health and safety of the public once we are ready to begin moving zones back to that level. We will continue to keep the public informed of any changes once we have made these decisions. Thank you again, Dr. Dow and Dr. Russell, for your important work. We'll now respond to questions from the media, as well as inquiries we have received from the public through social media regarding COVID-19 variants. Thank you. Merci.
Thank you, Mr. Shephard. Doctors Russell and Dow, merci beaucoup. Ms. Shephard, Dr. Russell, and Dr. Dow. We'll now proceed with questions from members of the media. Each reporter will have one question. You have the right to pose your question in the official language of your choice. Please ensure your microphones are placed on mute. We also have received a few questions on the variants from members of the public, and we will throw some in there. Nous allons maintenant procéder aux questions des journalistes. Vous avez le droit de poser vos questions dans la langue officielle de votre choix. Chaque journaliste aura une question. Voulez-vous assurer de désactiver le son de vos micros? Nous avons également reçu quelques questions pour le Dr. Dow. On va commencer tout de suite. We will now start. Adam Harris, Brunswick News.
Thanks, Bruce. I believe New Brunswick's been using the National Microbiology Lab in Winnipeg to confirm new strains of the virus. I wanted to ask about the lag in getting that information back and when there'll be a change so that New Brunswick has its own capacity to detect variants and what that will mean to the speed of detecting them.
Hi, Adam. I'm going to start with that answer, and if anybody wants to jump in after me, they can add to it. Right now, the lag time, the turnaround time is about a week, but because we know that the variants can be so concerning, if the medical officer has a really high suspicion even before a sample is sent, they will take extra precautions at that time. They're encouraging 21-day self-isolation instead of 14-day self-isolation, and they're trying to be very, very diligent and conscientious and probably a bit more aggressive with the contact tracing at this point in time. And there are other jurisdictions that are looking, so for instance, Ontario and Alberta are making changes to their case management approach as well. Again, knowing that if there is a turnaround time that is lagging, that if there's a presumption that, you know, once the variants become the circulating, the majority of the circulating virus that's out there, then again, we can presume that we have to take that approach with all cases.
Thank you, Mr. Harris. Laura Brown, CTV.
Following up on Adam's question there, will we have the capacity ever to be able to test for this variant or any variant ourselves? Are you saying that the 4 or 5 cases of the variant in New Brunswick right now are being asked to isolate for 21 days?
They are, and we are exploring options. We have conversations regularly with the Georges Dumont Lab, and so we're looking at being able to have that capacity, but that's not happening right now. But again, we're just trying to be as protective as possible, knowing that the variants are 30 to 70% more transmissible, and that, again, an outbreak caused by one of the variants can be something that would be quickly exponentially, an exponential growth in cases if that were to happen.
Thank you, Ms. Brown. Vicky Hogarth, CHCO TV.
Thank you, Bruce. Dr. Dow, you said that the new variants are 30 to 80% more contagious. What evidence is there right now around whether or not it's more deadly?
Thank you for that question. Currently, there is very poor data suggesting it's more deadly. So in other words, it's definitely more infectious, so it spreads more easily from person to person. The evidence that Boris Johnson talked about a week or two ago, indicating that it might be more deadly, has been reviewed very closely, and it is exceptionally weak data. So at this time, there is no firm evidence that it is more lethal. It is more transmissible, but it is not more lethal. I would like to say one other thing, though. I'm more concerned about more transmissible because increased transmissibility means that it spreads exponentially. An exponential spread means that mortality will go up exponentially. Well, if it's just more lethal, the death rate would go up at a much lower rate. So it really does not look to be more lethal, but I'm more concerned about the fact that it is more infectious.
Thank you, Doctor. Thank you, Ms. Hogarth. Bobby Jean McKinnon, CBC.
Yes, hello. Dr. Dow, given the fact the variants are more contagious, will more people need to be vaccinated to achieve herd immunity?
Yes, I think that's true. If you look at this whole concept of herd immunity, we don't know what it is for this virus. Herd immunity means that once you vaccinate a certain proportion of the population, just having that group vaccinated protects the others that aren't vaccinated. That number varies from virus to virus. Like, for example, the measles virus, you need to vaccinate 90 to 95% of the population to have herd immunity. Now, we don't know what it is for COVID. We've been guessing that it's around 70%. So we've been thinking if 70% of the population has been vaccinated, we could have herd immunity. That is far from sure. And one thing that puts it further into question, if you look at Manaus, Brazil, in the last year, because they did not have strong public health measures, over 75% of the population got COVID. Well, the new P1 Brazil variant moved in there in December, and it has now caused a brand new epidemic, and we see that it is reinfecting people that had previous COVID, and large numbers of people have gotten the infection. You probably saw in the news reports in the last month they ran out of oxygen in some of the major hospitals in Manaus, Brazil. What that tells me is that 70 to 75% is not enough for herd immunity because that city had a 75% infection rate.
Thank you. Simon Delac, l'Acadie Nouvelle.
Oui, une question pour la docteure Russell. Le Canada mise beaucoup sur les vaccins. J'aimerais savoir si vous pouvez nous parler de progrès d'autres traitements qui ne sont pas des vaccins. Est-ce qu'il y a des traitements qui pour l'instant ont fait leurs preuves?
La question est sur...
Simon, peux-tu aller plus fort sur votre micro, excusez?
Oui, une question. Donc le Canada mise beaucoup sur les vaccins dans sa stratégie. Est-ce qu'il y a d'autres traitements qui sont privilégiés à l'heure actuelle? Est-ce qu'il y a d'autres traitements qui ont fait leurs preuves pour le moment?
L'information que j'ai à ce moment-ci, il n'y a pas d'autres traitements que nous, on commence à utiliser ici au Brunswick à ce moment-ci, mais au fur et à mesure qu'il y aura d'autres recherches qui nous disent qu'il y a quelque chose de des possibilités d'utiliser quelque chose d'autre, il faut que ça soit quelque chose qui a de la preuve pour le supporter. Mais en attendant, notre stratégie, c'est vraiment de faire vacciner le plus nombreux de personnes possible, en particulier nos populations vulnérables, les résidents des résidences à long terme, les foyers de soins, etc., et les travailleurs de santé.
Merci. Marie-Ève Brassard, Radio-Canada.
Oui, bonjour. Ma question est pour Dr. Russell. En fait, Dr. Russell, j'aimerais savoir quel pourcentage en ce moment des tests sont envoyés pour être testés pour la présence du variant et si vous pensez à aussi élargir les critères sur lesquels on se base pour envoyer des tests à être analysés au laboratoire de microbiologie à Winnipeg.
Alors, à ce moment-ci, il y a deux façons que les échantillons sont envoyés à le Laboratoire national du microbiologie. Et les deux façons, c'est des échantillons sentinelles sont envoyés chaque semaine de chaque zone du Nouveau-Brunswick. Et aussi, en plus que ça, il y a des critères qu'il faut qui vont aussi envoyer des échantillons, et aussi les médecins hygiénistes dans les régies aussi ont la capacité de les envoyer aussi. Alors, c'est ça, depuis le mois de décembre, on a 213 échantillons qui ont été envoyés à Winnipeg. Puis ça, c'est des gens qui ont testé positif pour le COVID-19, puis on voulait examiner s'ils ont les variants. Et on a reçu 169 résultats négatifs. Et il y a 4 résultats qui ont été positifs pour le variant, et il y a 40 échantillons qu'on attend les résultats.
Merci beaucoup. Tim Roselle, Global TV.
Thank you, Bruce. My question is for Dr. Dow. I believe you mentioned during your presentation, Doctor, that the variants will eventually kind of overtake the initial version of the virus and essentially make it disappear. Is there a sort of a timeline for for when that process could take place, how long it could take place, and what it means for reporting cases of COVID-19 in New Brunswick? Maybe Dr. Russell would have to answer that part of it.
Well, thank you for that question. The best evidence we have for how long it takes is what we've seen in other jurisdictions. So you probably remember very well that the so-called Kent or UK strain of the virus started showing up in Britain in September, and they clued into the fact that there's something funny going on, because they were increasing lockdown measures in Britain during the fall and early winter, and yet they saw an increase in spread, and that's when they identified this new variant or UK variant. And between September and December, the UK variant completely took over and became the dominant virus, and the old strain significantly declined in prevalence. So it took 3 months. They've seen the very same thing in Manaus, Brazil, where the new variant showed up there in November, and again, over the next 3 months, the same thing has occurred. And I would expect to see the same thing in the United States. As you know, the UK variant has been identified there in many states, as well as some of the other variants. And I would expect that it would follow the same pattern. And as a matter of fact, the Center for Disease Control in Atlanta, Georgia, has done modeling, and their expectation is sometime in March, the UK variant will outnumber the old variant in the United States.
Dr. Dow, don't go too far.
Oh. And I just wanted to add that our approach throughout the pandemic has always been to keep COVID-19 out of the province as much as we possibly can, and if it does get into the province, to stamp it out as quickly as possible. With the variant being more transmissible and the capacity to cause more deaths as a result of the higher volume of cases we would see, we are working even harder now to keep COVID-19 out, including the variants, and trying to stamp it out as quickly as possible when it does get here. So that is why it's really important for us to continue to follow all public health measures.
Perfect. Thank you, doctors. Dr. Dow, this is a question we received from the public. I have heard that the new variants are showing more serious long-term issues for children. There was an article about it on CNN about info from the CDC tracking these cases.
Well, there is some truth to that, but we need more information. What we do know is that children were less prone to getting infected than adults with the old strain. Because the new strain is more infectious, children are more likely to get infected than they would have been with the old strain. So as infection rates go up, we would expect to see complications go up in children. What's not clear is whether the increased complications we're seeing in children are due to the variants or just due to the fact that children are more likely to get infected. Right now, most of the evidence suggests what we're seeing is due to the fact that children are more likely to get infected rather than the variant is somehow more problematic in children.
Thank you. Meg Cunningham, CHMA.
Thank you, Bruce. Dr. Dow, does the variant make indoor dining more dangerous, and will indoor dining be reevaluated now that the variant has made its way into New Brunswick?
I think that's going to be something that will have to be decided over time. Does it make indoor dining more problematic? Potentially, it's more infectious, so it might. On the other hand, restaurants that have a good operational plan will provide a fair, will provide good protection against all variants of COVID. Whether we need to enhance measures further remains to be seen. So that's, at this point, I would say that's an unknown. The good news about all of this is that our measures that we use work for the variant just as they work for the old strain of the virus.
Doctor? Minister?
I just want to add to that and thank Dr. Dow and Dr. Russell for that. We know how frustrating it is that rules can change quickly 1 week to the next. And one of the reasons is that data and information becomes more available each and every day, and it gets assessed by public health, and they make those recommendations to us. So one of the reasons we're working so hard to get our province back down to low numbers is so that we can resume some normalcy to the lives of New Brunswickers. And we will take direction from public health every time, and that's what your COVID Cabinet Committee and Cabinet its responsibility is to decipher that information that public health relays to us, and they get that information on a daily basis. So it's really hard to know what the near future is going to bring, but we will always keep you updated. Yes, most certainly.
And just to say that, again, as Minister Shephard has said, that we are getting new information all the time. And I think our hope has always been that if our vaccination rollout plan goes forward and we get the number of vaccines that we're expecting, that if the majority of the population is vaccinated by September, then obviously this will be a different environment, and we will probably have the ability to have different public health measures relaxed. But this is an evolving situation, and I think it's going to be a day-by-day, week-by-week thing as things change and evolve. But obviously, we're very, very hopeful with the vaccine rollout that we will see improvements in all facets of this illness.
Thank you. Kevin Bissett, Canadian Press.
Yes, good afternoon. Question for Dr. Russell. We've had a bit of a lull in the delivery of vaccines to the province, and I'm wondering what you and your officials have been doing during the lull to make sure you're prepared for the next burst of activity.
So the immunization task force is tasked with making sure that everything that needs to be done with respect to our immunization rollout is being done. Obviously, resource management is key, and making sure that everybody's ready to vaccinate when those supplies arrive. We definitely have had challenges with outbreaks right now, so in some ways we've used those resources very effectively in the meantime, but certainly when the vaccines arrive, the planning that has gone into all of that work is ready to go.
Thank you, Mr. Bissett. Savannah Odd, Brunswick News.
Hi there. My question is for Dr. Russell. I'm just wondering if you can give us an update on the province's rapid testing strategy. JD Irving, for example, the sawmill affected in the outbreak reported yesterday, has said it's part of a pilot with government in rapid testing. You also mentioned a few weeks back there were discussions around using it in long-term care. Could you, I guess, detail where those pilot projects are taking place? And the Premier also spoke to use in maybe incoming travelers. Is that also something that's happening? Thank you.
So I'll talk about the JDI issue first. We're collaborating with them, public health, and so what's going to happen is they're going to get tested on day 1, day 7, and day 14, a double swab. So one will be with the PanBio rapid test, which is a screening test. It's not a diagnostic test, but at the same time they'll have a second swab for the PCR, which is a diagnostic test. So that's going to happen on day 1, day 7, and day 14. And in between that, every second day, they will be tested with PanBio. Again, that's a screening test. It doesn't have the same sensitivity or specificity as the PCR test, and it's technically not really supposed to be used on asymptomatic individuals, but again, this is a pilot, so we are going to go down that route and see how this turns out. If any of those come back positive on that every second day with the PanBio rapid antigen screening test, then those people that turn up positive will have to get a confirmatory PCR test, again, because that is the diagnostic confirmatory test that would be needed. In terms of other places that rapid antigen screening tests would be used, and that includes the PanBio, the Abbott ID Now, and I think the BioFire is included in that. And I do have, we do have a plan for all of those as well, and some of those are up and running right now. So with respect to the targeted testing strategy that we've had throughout the entire pandemic, testing the right people, using the right method at the right time in the right way for the right reasons. Again, PCR will always be the gold standard, and we have the regular version of that and a rapid version of that, which is the Gene Expert. And those are used in all the labs in the major hospitals around the province. And the BioFire devices have just been started to roll out as well. So, and we take into account many different things when we're talking about the different types of testing, including the resources, including the epidemiology that's in existence right now in the community, and what type of reliability the different tests have, and what they're really best used for. So right now, we're going to continue to evaluate and reassess, but with respect to the BioFire, that is another rapid PCR-based test, just like the Gene Expert, and they can get a test result back in about an hour. And what we're going to be using those for, we're going to test for, we can test for influenza with that, and then we can also use that with inpatient transfers to ICU, pediatrics, and patients who are immunosuppressed. And knowing that for the screening rapid tests, again, these are best used on symptomatic people within 5 to 7 days of the onset of their symptoms. And so again, when we look at using them in different places, we are looking at for the PanBio, we are, and again, not all of this is confirmed, but these are the discussions we're having around where it can be used. We're looking at communal living settings such as correctional facilities. We are also looking at the Abbott ID Now being used with the prompt teams for supplementing the use of the Gene Expert, and also in other non-hospital facilities as a rapid screening tool. And again, it doesn't replace the PCR-based diagnostic tests. And again, because the sensitivity and specificity are lower with the rapid screening tests, they have to have the confirmatory PCR test. So again, wherever and whenever we can use the other tests, we will. And again, it will be in combination with all of the other testing strategies that we have.
Thank you, Ms. Odd. We're going to go back to one quick public question. Actually, we're going to take a 2-minute pause. Just bear with us, folks.
the variant?
So right now we have 40 tests that are pending. And again, because the turnaround time is a week, my assumption is that those are from a week ago or less, but I can't confirm that right now, but I can get back to you with that information.
Thank you.
Thank you. So I just want to make sure I got the second part of your question correct. Would you mind repeating it, please?
Yes, I'm wondering what impact this kind of week-long delay is having on our ability to understand how the variant is working and our ability to contain it.
So I'm sorry, I didn't hear the first part of your sentence. Would you mind saying that one more time?
Yes, sorry about that. Can you hear me okay now?
Yes.
Yeah, I'm wondering what this 1 week lag is having on our ability to understand how the variant is working and respond and contain it.
I don't think a 1 week lag is going to be a significant problem for us. That lag would be seen in most jurisdictions around North America. And our initial responses to clusters of COVID would be the same initially, whether it's a variant or the old strain. The things that work for the old strain work for the new strain. What we would do, depending on the degree of an outbreak, is we would just apply more stringent measures as time went by. And we would do that whether we knew it was a new strain or an old strain. So no, I don't think that 1 week delay is going to impact our response in any way.
Thank you.
Very much.
Dr.
I don't know if she hung up already, but technically they're going to be self-isolating for 2 weeks anyway, so 1 week they'll be isolating at the time that we would get that information back.
Thank you. Dr. Dow, how confident are we that the UK variants are cause for concern? To my knowledge, the study everyone references is not yet peer-reviewed, and most articles on the topic are hedged with the words may, possible, could be language.
Yes. That's part of the problem with the pandemic is most of the information as it comes out in phases. First, it's a media release, and then following that, there's a non-peer-reviewed publication, and then maybe a month later, a peer-reviewed publication. So yes, there is a problem in getting all of the information you would like to see. However, I do believe the information we're getting on these new variants is accurate, given that we now have data going back to September of 2020, and we're seeing this increased spread and replacement of the old strain with these new variants in multiple jurisdictions. We're seeing it in Ireland, in the UK, we're seeing it in Scandinavian countries, we're seeing it in South Africa and Brazil. So I would agree, when that initial data came out in December about the UK variant, we were all looking at it very critically. But now that we've had multiple experiences that have been identical to the UK experience, I feel quite confident that the ability of these variants to replace the old variants is real.
Thank you. Isabelle Larose, Radio-Canada.
Oui, bonjour. Ma question est pour Dr. Russell. Le Nouveau-Brunswick a annoncé il y a bientôt un mois une nouvelle directive qui demandait aux résidents québécois de Ristigouche et Pointe-à-la-Croix et à tous les travailleurs de la Gaspésie qui travaillent au Nouveau-Brunswick de passer un test de dépistage chaque semaine pour pouvoir traverser la frontière. Pourtant, les travailleurs nous disent que les agents frontaliers ne demandent pas la preuve de ce test-là depuis l'entrée en vigueur de cette directive-là. Alors, pourquoi avoir annoncé cette directive si elle n'est pas appliquée? Et comptez-vous le faire, à un moment donné, la mettre en œuvre concrètement sur le terrain?
Oui, je comprends la question. À ce moment-ci, c'est vrai, ils vont pas demander pour le test, mais c'est vraiment pour être en toute sécurité quand on a des voyageurs qui vont venir de d'autres endroits en hors du Nouveau-Brunswick. Alors, pour le travail, pour les gens qui viennent, qui vont et viennent chaque jour avec leurs activités, c'est vraiment important d'avoir le test négatif chaque semaine. Et il y a 7 endroits qui peuvent faire tester. C'est Clare, Hamilton, Edmundston, Grand Falls, Grand Sault, Heartland, Perth, Andover, St. Stephen. Et il y en a une juste à côté de notre frontière avec Nouvelle-Écosse. Alors, il y a 8, je m'excuse, endroits pour se faire tester. Et c'est vraiment facile, aussi Sackville. Et c'est vraiment facile d'enregistrer, inscrire pour un test. C'est facile, c'est vite fait. Et c'est vraiment aussi, c'était nécessaire de éliminer les risques de le virus le plus tôt que possible. Alors c'est pour ça qu'on va encore ils vont avoir la capacité d'avoir ces tests. Mais je comprends, oui, c'est à ce moment-ci, ils n'ont pas besoin de fournir leur test négatif.
Merci. Harry Forstall, CBC. Harry.
Thank you, Bruce. Forgive me, I missed the top of the news conference. This question may have already been asked, but to Dr. Russell, New Brunswick is apparently using only just over 4% of the federal rapid tests for COVID-19 that have been supplied. Prince Edward Island is using 25%. Dr. Michael Garden has said they're not perfect, but they have a valuable role. Why are we not using more of the rapid tests right now in New Brunswick?
Harry, I'm going to take the first part of that, and I need to speak to the fact that we've been very strategic with our rapid testing. One, and Dr. Russell can better explain the fact that they are, they are not diagnostic; they are screening. And so the most important thing for us is to use the gold standard tests that we have been using all along. Now, having said that, we have been using them strategically in the ERs. We have we've been now working with companies to be able to use them when we have an outbreak, and as you heard, we're piloting with JDI at the St. Leonard plant right now, and we will continue to now progressively use them for our daily commuters. And for those situations where we know we're going to be having to do weekly tests, but we're going to back those up by sending, those tests to the George Dumont lab in order to ensure that they're accurate. And so we have been very strategic, and I'll also just add that we could not be guaranteed supply from the federal government, so we kept them for when we needed them. We did not use them without having a real strategy for it. And if Dr. Russell needs to add anything with regards to the quality, I'll let her talk to it.
Yeah, just 2 points to add, really. One is to remember that no matter when you get tested, it is a snapshot in time. So if you test positive, okay, great. We know you're positive. But if you test negative, that doesn't mean that you're going to remain negative. You could become positive later that day or a couple of days later. So there will always be a risk with anybody coming into New Brunswick for whatever reason. If they're not self-isolating for 14 days, there is a risk of bringing COVID into the province and transmitting it. Number 2, with respect to the screening antigen tests, the rapid test, PanBio and Abbott ID now, they are meant to be used for symptomatic people within 5 to 7 days of the onset of their symptoms. They do have the risk of having a false positive, which is inconvenient, but it's not as dangerous as a false negative. And a false negative is very dangerous because that means that somebody would have received a negative result and not know that they were actually positive and not know that they were actually transmitting COVID-19.
Thank you. We're going to go back to another public question. Dr. Dow, will our current vaccine provide any protection against all the new variants?
So the current vaccines approved in Canada are the Pfizer and Moderna mRNA vaccines. Those two preliminary reports from both of those manufacturers are that their vaccine is effective against the UK variant. Some other vaccines that are under investigation right now have shown reduced efficacy or reduced effectiveness when they've been studied in South Africa. But that data has not been yet peer reviewed. But for now, the data is encouraging for the mRNA vaccines that we currently have in use in New Brunswick.
Thank you. Rebecca Martel, CBC. I have other questions here. If these variants are so much virulent, why are the daily cases dropping dramatically in the UK, South Africa, and Brazil? Why are these variants being used to justify further restrictions when the R number in the UK is currently 0.7?
That's a super question. So our reproduction number is low, but that's also because we have very effective public health measures, and we've got a population in New Brunswick that I am very proud of that has been very engaged and working very responsibly with the Chief Medical Officer of Health and the guidelines coming from Dr. Russell's office. The issue with variants is that they're more transmissible. They're actually not more virulent. More virulent means that they're more likely to cause disease. We actually don't have any data to show that they're more virulent or more likely to cause disease. We've got data to show that they're more contagious, so they're more likely to go from person to person. So that means as long as people are following the guidance that we talked about earlier this morning, we can keep the variants under control and make sure that New Brunswick continues to be the safest place to work and live in North America.
Thank you. Il semble que nous avons 3 variants de ce virus et que les variants sont plus contagieux et dangereux. Il est donc possible qu'il y aura d'autres variants? Est-ce que ça veut dire que nous sommes pris à ne pas trop voir nos familles, amis, tant et aussi longtemps qu'il va sortir des variants?
That's a super question as well. So to answer that, we will be able to get ahead of this virus and these other variants. And you are quite right. We are going to continue to see new variants over time because this virus, like many other respiratory viruses, mutates on a regular basis. And we know how fast the mutation rate is. It's not as fast as influenza, but influenza mutates at 10 times a faster rate than this virus. But it does mutate. So because influenza mutates, we have to come up with a new vaccine every year. But we have influenza under great control because of public health measures and vaccination. I would expect the very same thing with this virus. Yes, we're going to see new variants over time. I wouldn't be surprised if we see some vaccines work better than other vaccines. But if we continue to follow public health guidelines, modify vaccines as necessary, we should be able to have things gradually open up. As a matter of fact, I would expect that there will be, that we have a bright spring ahead of us. I would go so far as to say, and an even brighter summer, as long as we continue to follow current guidance.
you, Doctor. Est-ce que les cas positifs des éclosions dans le foyer de la zone K ont été testés pour les variants? Et si oui, quand est-ce qu'on va avoir les résultats?
Alors, je crois qu'il y en a des échantillons qui ont été envoyés. Je ne sais pas si on a déjà reçu des résultats puis ils ne sont pas positifs pour le variant, mais je peux m'informer aussi. Si on aurait reçu des résultats que c'était positif pour le variant, on l'aurait reçu à ce moment-ci. Alors, soit on n'a pas reçu encore ou le résultat c'était négatif pour le variant.
One more question here. Has there been any sort of cost-benefit analysis done on extending lockdowns, in response to the UK variants?
No, there haven't been any peer-reviewed publications that I've seen looking at the costs of lockdowns with new variants. In fact, we don't really even have good data on all of the costs for lockdowns with the old variants, and part of the problem here is it is very difficult to count the costs because some of the costs are measurable and some of them are beyond measure. But at this point, we don't have good data on what the costs are. What we do know is that the costs of complacency are completely unaffordable.
Last one. I lied. If a person has already had COVID, could they get the COVID variant or COVID again?
Yes, so there's a very interesting trial out of England, published in December, called the Siren trial, and it showed that if you had the old variant and you followed that person for 6 months, there was an 85% reduction in the risk of getting COVID. So if you had the old variant, you were protected at least for 6 months. What we're seeing in South Africa and Brazil is there's some preliminary evidence showing that if you had the old variant in either of those countries and then were exposed to the new variant, you would get reinfected. So yes, it looks like the new variant, at least in some countries, will infect people who were previously infected with the old variant. So infection with the old variant doesn't give you a guarantee that you won't get infected with the new one.
Rebecca Martel, did you join back? Merci beaucoup. Thank you, doctors, minister. This terminates today's presentation. C'est terminé nos présentations pour aujourd'hui. Merci.